Hey there, I am Dr. Christopher Fox, and I'm here today to talk a little bit about the basics of hypothyroidism. What are the symptoms? How is it diagnosed? How do we treat it? Really, to hopefully allow you and I to be on a fairly compatible level, to have the basic understanding down for how I think about thyroid, how you might think about thyroid, so that when you and I meet, we can really spend the most time at the high level trying to dive into the specifics of your circumstance, what your problems are, if any, that you need help with, and how we might go about solving those. So with that as a brief introduction, let me just dive right in here. I am going to jump behind the slides here. You'll see me down in the corner. Let me just scoop myself over. And again, we are talking about hypothyroidism, or some of the basics about hypothyroidism. My hope in this short training is to cover some basics about thyroid physiology. What are the causes of hypothyroidism, the symptoms of hypothyroidism, how do we diagnose it, how do we treat it, and what are some of the specifics about thyroid treatment that are important for you to know. And then we'll conclude with a few frequently asked questions that seem to come up a lot these days that may not fit nicely into one of those other categories. So for me, when I think about thyroid problems, if we think about it, we're all supposed to have a thyroid gland, little butterfly-shaped gland, lives right down here in the bottom portion of your neck, and it makes hormones that control your metabolism. We'll talk about this in just a minute. When I think about thyroid problems, I like to break them into two general categories. So there can be functional problems. This is where the gland might be overactive or underactive, hyperthyroid or hypothyroid. And there can be structural problems, unusual shape, size, lumps, or bumps. And people can have one category or the other category or both categories, or if thyroid's perfectly normal, obviously neither category. And so this training, again, we're going to focus in on the underactive thyroid, what we call hypothyroidism. So some basics about physiology. Again, the thyroid gland is this butterfly-shaped gland that lives in your neck. It makes two hormones, actually, that are called T4 and T3. The numbers just have to do with how many iodine molecules, or iodine atoms, I should say, are stuck onto the thyroid hormone molecule. And the thyroid gland, when it's working well, secretes about 95% T4 into the blood, and then about 5% T3 directly secreted into the blood. But then these hormones travel through the blood. They go to your tissues like your heart or your muscles or your brain. And at the tissue level, your tissues all respond to T3. So your tissues can bring in T4 from the blood, and inside the heart tissue or the muscle tissue can convert that to T3, which affects how the tissues function, how the heart functions, how the brain functions. Now, the thyroid gland is under the control of a little gland back behind your eyeballs, under the front part of your brain called the pituitary gland. The pituitary can actually sense how much thyroid hormone is in the blood, specifically how much T3 is available to the pituitary. And it then regulates this hormone called TSH, or thyroid stimulating hormone, in order to try to keep the thyroid at the right level. So it's kind of like the thermostat regulating the furnace. And so that means that when we see low thyroid function, as the thyroid becomes underactive, pituitary will sense that, and TSH will actually rise. So if we think about T4 and T3 levels in TSH, under most circumstances, when the pituitary gland is working well, they're going to go like a seesaw. As T4 and T3 go down, TSH will go up, and vice versa would be the case for overactive thyroid gland. Okay, so when we think about low thyroid function, hypothyroidism, why does it happen? Well, probably the most common thing that we see is something called autoimmune thyroid disease, or you'll hear a lot of people use the term Hashimoto's, named for a Dr. Hashimoto in Japan, who originally described the combination of low thyroid function with thyroid enlargement. And autoimmune thyroid disease can be diagnosed measuring these things called thyroid antibodies. So you may see those on a lab report, TPO antibody or thyroglobulin antibody. Sometimes we get a sense that it's there, or we make the diagnosis on ultrasound, the thyroid tissue being what we call heterogeneous. Or sometimes if you're having a biopsy of your thyroid, say for a thyroid nodule, we might see changes that demonstrate this autoimmune thyroid disease. Now, it turns out people can get low functioning thyroid, hypothyroidism, for a number of other reasons. Probably more commonly, these would include surgery for thyroid cancer or other benign thyroid conditions like thyroid nodules. people who've had radioactive iodine for overactive thyroid, or perhaps external radiation for another type of cancer. So, for example, head and neck cancer would be fairly common, that if the thyroid is in that radiation field, it can be damaged and ultimately become under-functioning. And so the symptoms of low thyroid, they're long and varied. They include things like fatigue or brain fog, poor concentration. People may gain weight. They may feel constipated, muscle pain, cold intolerance, dry skin, hair loss, heavy menstrual cycles, depressed mood. It's a whole long list of symptoms. And one of the troubling things with these symptoms is they're what we call nonspecific. And that means that although these symptoms may be caused by low thyroid, they can also be caused by a lot of other conditions. So not everybody who has fatigue or weight gain or cold intolerance will turn out to have low thyroid function. And so generally we make the diagnosis looking for a combination of compatible symptoms. So we would typically recommend testing if you have symptoms that in theory could be caused by the thyroid, and then supportive blood test results. And that will generally be, as we look at in the physiology, a combination of the elevation of TSH and a low normal free T4. Now, on the internet, you may read that there are 7 tests or 14 tests, or who knows the number of critical thyroid tests that are important for the diagnosis. And a lot of this is really driven by marketing or not supported by science. So for most people, standard low thyroid function, what we'll see first is that the TSH will be the first thing that becomes abnormal, and it will rise out of the normal range. Second thing will be the T4 level will drop out of the normal range, and third thing will be T3 levels will drop. And you may or may not have T3 levels measured. That can be an important thing under certain circumstances. But the majority of people who have low thyroid can be diagnosed just with this combination of the elevation of TSH and low normal free T4. Now that asterisk there by TSH is just to remind me to let you know that there are certain circumstances, particularly when the pituitary gland is not working correctly, where the TSH becomes no longer reliable for measuring thyroid function, and we have to rely on the T4 and perhaps the T3 level. Now, as we think about the TSH level, I want to give you this little diagram just to have in your head as we move forward. TSH, the normal range on most tests, goes from about 0.4 up to 4.5. But I'm going to put in 2 other markers here, one at 2.5, and this is because most people who are truly normal for thyroid will have a TSH that's below 2.5. And so there may be some people, and it's probably not everybody, but there may be some people who have a TSH between 2.5 and 4.5 who actually are mildly hypothyroid and may have symptoms that could warrant treatment. And I'll put in another little marker over here at 10. And so what we would say is that truly normal is going to be between about 0.4 and 2.5, and that's generally going to be the range that we shoot for when we are treating people with medication. And for people who live in this 2.5 to 4.5 range, or even the 4.5 to 10 range, there is an option to try thyroid hormone to see if it's helpful for the symptoms. But it's not mandatory. It's not mandatory because we know for people who are feeling well, there may not be benefit, or there's not been proven benefit to treating the thyroid when it is mildly underactive. Now, again, it may be beneficial for you and your symptoms, but in terms of helping you live longer or avoid downstream complications, we really only know that that becomes important when the TSH is above 10. So in general, if the TSH is consistently above 10, I will push you to say, gosh, we really should probably treat this in this circumstance. Now, there are a couple exceptions to this. For people who are pregnant, women who are pregnant, we do want the thyroid to be treated a little bit more vigorously. For people with chronic kidney disease, there may be benefit to treating a little bit more vigorously to try to keep that TSH below at least 4.5 or below 3.0 during pregnancy. So how is low thyroid treated? The standard treatment is with a medicine called levothyroxine, which is T4. And so that's given, we give it in a sufficient dose, ideally to bring your TSH into our target range. Again, for most people, between 0.4 and 2.0, although this can be individually adjusted. We want to bring the TSH into the normal range, and we want to alleviate symptoms. And so both of those things are important. And sometimes physicians get lost with that second piece, alleviating symptoms, and end up really focused on just the numbers. And that leads to some conflict. And it's one of the reasons why sometimes people come to chat with me. Now, just some general notes about treatment. If you can get one of the brand prescriptions of levothyroxine, Synthroid, Levoxyl, Unithroid, Euthyrox, some of these are very inexpensive. Now, if you get the brand, it may be beneficial. And this is really just because we like you to be consistent with what you take. We don't want you switching from one product to another product to another product, because every time you switch, they may be a little different in your body, and that can lead to some unnecessary fluctuation in your levels. If you are on the generic thyroid hormone, so just called levothyroxine, ideally you can work with your pharmacy to get it from the same manufacturer. And levothyroxine, or any of the brands, these are generally taken, or they should be taken on an empty stomach, and at least 4 hours apart from vitamins, minerals, soy products, fiber supplements, a couple medications, sertraline and raloxifene, or any other substance that's known to interfere with the absorption. So if these things are in your stomach at the same time as thyroid hormone, they can keep you from being able to absorb that thyroid hormone. So for levothyroxine and its preparations, most people take it either first thing in the morning when they get up or last thing when they go to bed, ideally at least 2 or 3 hours after the last time you have eaten. Now, your dose will be adjusted based on your symptoms and your blood results. And for most people, once the dose is found, it tends to be fairly stable, but it can change, in particular in the first few years of therapy. So if your thyroid is gradually losing function and you need a pill to bring you back up to normal, if your thyroid loses more function, you may need a bigger pill in order to make up that difference. We do see when people have large changes in weight, that can affect the thyroid dose. Starting or stopping estrogen or birth control or going through menopause, basically anything that changes the estrogen status in your body can influence your thyroid dose. So in general, higher estrogen, more thyroid hormone is needed. And that's true also for pregnancy. And pregnancy is kind of a special case because we know that thyroid hormone is really important for babies' neurological and brain development. And so when women are pregnant, we do monitor the thyroid much more closely and often need to make several dose adjustments during pregnancy. So we always like to know if you find out if you're pregnant and you're on thyroid hormone, let us know so we can help coordinate that follow-up testing. One other thing that is not on this list is acid suppression. Anytime people start or stop acid suppressing medication, sometimes that will affect the dose as well. Anytime we make a change in medicine, typically we will want to recheck levels about 6 or 8 weeks after that change. It does take about that long for everything to come back into balance after a dose change. And just be aware that high-dose biotin, so sometimes this will be present mostly in products that are marketed for the benefit of hair and nails. High-dose biotin, so anything that's in the 4-digit range, 1,000 micrograms or above, can interfere with the results of thyroid testing. So you want to stop that at least 3 days before your thyroid test. And you'll want to let me know or your provider know if somehow you're having symptoms that might say we've overshot or you're on the too high side, heart racing, shaky, anxious, jittery, tremor, or sweating too much, irritable, having a wired sensation. These are all things that are important to let your doctor know that maybe we've gone too far with the dose. Now, as we start to wrap up, I will tell you that one of the questions that we get is, should I also be taking T3? Remember, we talked early on how thyroid gland made 2 hormones, 95% T4, about 5% T3, and the standard treatment is just to give the T4 and let your body convert that into T3 as it needs to. Well, people have asked about that 5% T3. Maybe there is something important about that. And we know that people have variations in the enzymes that metabolize thyroid hormone. And definitely we see that there are some people who are treated for low thyroid who don't have complete alleviation of their symptoms. Now, of course, that could be that those symptoms are coming from something that's not the thyroid. But one of the things we would think about is standard T4 therapy, levothyroxine therapy, the best thing for that person? And there was a study that was done way back in 1999, so now over 20 years ago, that suggested people who took a combination of T4 and T3. So in that study, they reduced their T4 dose a little bit to make room for the T3. T3 called liothyronine, or there's a brand named Cytomel. Generally, you'll see it marketed as liothyronine. They found that people felt better, they were cognitively sharper, they were more energetic, they were less depressed when they were on that combination. Now, that study's been repeated more than 15 times, and nobody really ever duplicated those original results. And so what I would tell you is the combination therapy is not clearly better than standard therapy. It's also not clearly worse than standard therapy. It's just different. In those studies, there does seem to be a subset of people for whom the combination seemed to work better. People preferred that combination, even when they didn't know what they were getting. They preferred that combination over the standard T4 therapy. And so this combination therapy really becomes an option primarily if you're not feeling well on standard therapy. And again, it would generally be a treatment with either the levothyroxine or brand combined with liothyronine, or it can be given as something called desiccated thyroid hormone. And so these are names like Armour thyroid or NP thyroid or Nature thyroid or WP thyroid. Okay, let's just end with a couple FAQs here. So first one, do I need to change my diet? Questions come up quite frequently about, do I need to be gluten-free? Do I need to be dairy-free? Do I need to watch how much broccoli I eat? How about soy products? And what I would tell you, let's look at the first two, dairy and gluten. Definitely, some people are sensitive to those. And if you are somebody who is sensitive to gluten or sensitive to dairy, then by all means, there's no reason you need to consume these. But we also don't have evidence that for the standard person who's not gluten sensitive or who has celiac disease or the standard person who has lactose intolerance, if you don't have any of those conditions, we don't have any evidence that going gluten-free or dairy-free actually improves the thyroid function or is beneficial for the thyroid. So we don't generally counsel people with low thyroid that you have to do this. Cruciferous vegetables like broccoli or cauliflower or watercress do have a very minor anti-thyroid composition to them. They're able to inhibit the thyroid just a little bit. Now, for most people, this is really not enough to be clinically important. So I think if you are somebody whose thyroid function is just barely hanging on at the low end of normal and you were to eat boatloads of broccoli, you might be able to tip yourself over into low thyroid. But for the standard person, we know that these vegetables can be part of a very healthy diet. I spend a lot of time trying to convince people or help people to consume more vegetables, more broccoli. And so again, I don't counsel people with low thyroid to limit intake of cruciferous vegetables. And then soy protein, interestingly, we do know that soy protein, if in your stomach at the same time as thyroid, can keep you from absorbing thyroid hormone. So that was on that list of things to separate out by at least 4 hours. But other than that, soy consumption, again, is not likely to change thyroid function to a significant degree. How about high doses of iodine? Sometimes people are told that they are iodine deficient and need to take a lot of iodine in order to help repair the thyroid. And this is one of the places where the information really can lead us astray, can be somewhat damaging. We know in the US that it's very hard to be iodine deficient if you're eating, really a normal diet, a healthy diet with normal food. Perhaps a few women during pregnancy may be a bit low on iodine. And so if you're concerned about that, taking a multivitamin with 150 micrograms, the RDA of iodine, would be fine to do. High doses, somewhat confusingly or paradoxically, can actually, in people who are at risk for low thyroid, can actually shut the thyroid down. So we see high doses of iodine can actually make hypothyroidism worse. So we don't recommend that people consume above the RDA. How about this? Is there anything that I can do to stop or reverse the loss of thyroid function? And, we're a proactive society. People like to be able to do things that if you, say, have autoimmune thyroid disease, Hashimoto's, and your thyroid is losing function, could you stop that from happening or even reverse it and recover? Short answer is we don't have anything proven. I will tell you about 2 substances that you could think about taking. First one is selenium, 200 micrograms per day. In some studies has shown that maybe it reduces antibody levels or reduces that immune reaction. The second one is there's a small study that looks at a substance called ashwagandha, an Ayurvedic medication, ashwagandha, and I believe it was 500 to 600 milligrams once per day, may provide benefit. Again, not proven. We don't generally recommend that everybody take this, but it would be a reasonable thing if that fits within your preferences and values. And then let's see here. Finally, I feel fine. Do I have to take medicine? My doc told me I have low thyroid. My TSH is high. Do I have to take medicine? What we generally say is for people who have no symptoms, who have normal kidney function and are not pregnant, if your TSH is below 10, then generally it would be fine simply to monitor and treat when the TSH goes above 10. But for those of you whose TSH is above 10, we do see changes in cholesterol and heart function that may predispose to some problems down the road. Okay, so I am going to wrap up for this training. Again, we've covered a lot in this training: thyroid physiology, causes of low thyroid, hypothyroid symptoms, diagnosis, treatment, hypothyroid FAQs. I do have a handout for people with low thyroid. Hopefully, if you are coming to see me, you have either received that or you will receive it. When we are together, you can ask for it if you don't have it already. It kind of supplements and provides a little bit more background to a lot of what we've covered today. And so as I wrap up, I would just say, hey, I am looking forward to meeting you when you come to clinic. I'm looking forward to meeting you, to getting to know you, and kind of how you work, what's important to you, what problems we need to focus on. Do make sure before your first visit with me that you get your registration form in and your medical history form in. Again, that will help us to be at the highest level when we are together, and I look forward to meeting you. Till then, I wish you peace. Take care.